Get ready to enter a brave new world with your host, Vasant Dar.
Brave New World is supported by the Center for Data Science, or CDS, at NYU. If your organization is interested in engaging with CDS through student projects, please email cdsindustry@nyu.edu. For more color on the podcast and additional commentary, please subscribe to our newsletter at vasantdar.substack.com. Hello, and welcome to Brave New World. My guest today is David Sontag, who is professor of computer science at MIT. I'm really excited to talk to David because medicine is what got me into AI after I witnessed an interaction in 1979 between an expert physician, Jack Myers, and internist, which was the first AI system that performed medical diagnostics covering the field of internal medicine. A lot has happened in AI and medicine since then, so I'm really looking forward to getting up to speed on the latest thinking in AI and healthcare. I have little doubt that AI will eventually surpass humans in its ability to provide individualized high-quality healthcare. It'll have access to knowledge that far exceeds what the best expert sees in their lifetime, and I think it'll be able to better connect the dots than humans. But at the moment, I think we're still in the early innings. David, welcome to Brave New World. I am delighted to have you on the show.
Thank you for having me. It's good to be here.
You know, David, we've known each other a fair bit of time. You know, you were at NYU and now we're at MIT, but I realized that I know precious little about your personal life, where you grew up, what impacted you growing up, and ultimately how you got into this whole space of AI and healthcare.
Yeah, well, I'd be very happy to walk you through it. Maybe I'll start from the present and work, then do a bit of time travel to go back. So now I live in Brookline, Massachusetts. And as you said, I'm a professor at MIT. I have a 6-year-old son and been really enjoying this combination of work-life balance with my new family. But if you go back in time, perhaps 30 years ago or more, I grew up in New Jersey. And from a young age, I was really interested in computing. Spent a lot of time during the early .com era doing consulting work, both for industry, also for working for a nonprofit organization. And as part of that, got really interested in how one could use technology for social impact. And that's something that really guided me the rest of my life.
And what took you towards healthcare?
So in my early years of my education, I focused on machine learning. I studied machine learning at Berkeley, where I was an undergrad student in California, and then went over to MIT and did my PhD, continuing to study machine learning. And at both of those points, it was really theoretical, my work. So I was looking at really how one can use machine learning methods to do reasoning. So if you think about a human, for example, having some observations or some evidence, like, for example, you see a chair being pushed and you might use some of your knowledge about the friction of the carpet in order to make some conclusions about how long until it'll hit a wall. How can you build machines that can do reasoning like humans can? But when I finished my PhD and was looking around to, well, what do I want to do next? I was looking for an area where I could put one foot in that more theoretical side of machine learning and the other foot in some more applied area that would provide focus for my research and make sure that I wasn't just solving theoretical problems for the sake of solving theoretical problems, but could really work on something that would matter for the long-term future of the artificial intelligence field, and at the same time would also have an impact in the world outside of the broader machine learning area. And so I landed on healthcare as being that applied topic that I thought would be really important to society, and at the same time, a never-ending source of interesting challenges for the machine learning field.
You know, it's interesting that we both sort of got our start in AI in the health arena, even though I sort of was much earlier. And, you know, because my first exposure to AI was the internist diagnostic system.
Yeah. Can you tell us a bit about that?
Sure. The internist system was created by Harry Popel at the University of Pittsburgh. And it was the first AI diagnostic system that covered the field of internal medicine. I'll never forget my aha moment. Well, a couple of PhD students came to me and said, hey, we want this guy to offer a course in AI. Will you come with us? We want to show strength in numbers. And I said, sure, what is AI? And they said, well, it's about getting computers to be intelligent. I said, oh, that sounds really good. Yeah, let's go. So we went up to the medical lab at the University of Pittsburgh Medical School. It was a lab, on the 12th floor on its own. And so we were waiting for him. He was on the phone talking to someone. And so I was just standing there looking at this physician. His hair was completely white and he was puffing a pipe and quote unquote talking to a screen through his assistant. And they were discussing a case. And the computer asked, he entered a bunch of symptoms about a case, and then the computer asked him a bunch of questions, which he answered, and the computer asked him another question, and he said, why are you asking me this question? And internist said, well, because the evidence you've given me so far is consistent with the following set of hypotheses, and this question will help me discriminate between the top few. It just blew my mind. I mean, I had no idea that a computer could do that, because I'd done engineering and solved, differential equations numerically, and that was my notion of computers. So that was my aha moment. It was like, wow, like whatever this thing is doing, I want to know how to do it, and I want to be doing this kind of thing. So,
do you remember what year that was, approximately?
Yeah, it was 79. It was September of 1979. They'd been working on internist for about 10 years, and it was quite remarkable in terms of its diagnostic accuracy, because I spent most of my time up in that medical lab, like days, nights, everything. And so I got to witness a lot of physicians coming and talking to an internist, and they'd walk in and say, oh yeah, let's run this case. And they'd run the case, and I'd hear, people laughing. I'd hear hoots. I'd say, oh, that's stupid. Oh, wow, that's interesting. Right. So it was like really interesting to hear all these humans reacting to this machine, discussing a case with them. And
yeah,
very
so
often
when I teach my machine learning and healthcare class at MIT, I actually start out with exactly that example of internist. And I start from there. That's day one of the class.
Wow. How about that? Yeah. Well, so that was my sort of exposure, right? And I realized how long it had taken people to build that system, multiple people, 10 years of effort, talking to Jack Myers and a few other experts in diagnosis. And so just a ton of effort had gone into building that system, and it performed really well, but it was kind of, you could feel that it was brittle, that it could, on the edges, it just would not, I guess the word is degrade gracefully.
Yeah, but there were aspects of that system that look very familiar in today's world, right? So first of all, a chat-like interface for communicating with the assistant, the ability to really do reasoning about very complex concepts, an attempt at interpretability to explain its reasoning. So I'd say, it looks very familiar to someone who is perhaps not in the AI field, who's looking at the advances in AI today. And when I teach this example in my class, I usually then follow up by asking a question to the students, which is, okay, so how many of you have seen systems like this used in your doctor's office today?
And
the answer is always no one.
Yeah, exactly. Now, so why is that? And by the way, I want to come back to this issue that you just raised, that, things seem kind of similar now, right? We've got agents that we can talk to about a case, right? But We're talking like 40 plus years later, right? And I must say, I haven't sort of kept in touch with the field of AI in internal medicine at the level of detail that I was, many years ago. But it seems to me that we sort of went away from that notion of a physician interacting and discussing a case with the system, right? We spent a lot of effort trying to build those kinds of systems until the late 80s, early 90s. And then we sort of, we almost like gave up on them. And the field shifted towards data and machine learning and prediction and all of that stuff, as opposed to sort of building systems by asking experts for knowledge and then codifying that into a system. The emphasis went towards sort of using data to sort of learn these quote unquote rules.
I think actually you're conflating two different aspects, right? So the first one is about what is the use case, and there you have a use case of a physician interacting with the system, like running a case that they're trying to do a diagnosis for through the system. And then there's a different question, which is also really interesting of, well, how do these systems work? And those systems that you were alluding to from the 1970s being very much knowledge-based driven, whereas the field moving to much more data-driven, machine learning-based approaches. But even in the first, just from a user experience perspective, I think there's a really interesting question of, well, why did the field move away from systems that are diagnostic assistants toward other use cases of machine learning in healthcare or of AI in healthcare? I think there's a really interesting user experience question, which is, if you go back to the 1970s, why did your physician colleagues think it would be helpful to be able to interact with a computer to talk about a case?
Yeah, great point about that distinction between the source of knowledge and the use case involving interaction, reasoning, and explanation. I think the bottom-up data-based approach to knowledge creation led to an emphasis on prediction and away from reasoning and explanation, which, interestingly, we seem to be coming back to with chatbots and GPT. I mean, at that time, they were trying to put the best expert knowledge into a system with the expectation that it would become available for use by non-experts.
Yeah, I view that much more as a research project. And if one were to think about what would have taken even back then to translate into that into a product that would have been used widely, I think that the user experience never quite gelled, right? You have to walk over to a mainframe computer or wherever you had your computer, which is probably not by the bedside of the patient, enter in their information manually. So even if you knew a lot about the patient, but the computer didn't know about it because there were no electronic health records at the time. So you had to enter in a ton of information in order to get any recommendations whatsoever. And the system might have been built at a place like University of Pittsburgh Medical Center, which is a top teaching hospital, but the clinicians where you might want to really use this with, who don't have a more senior physician who they could just turn to and ask a question to, probably are in more rural areas. And so that question of really getting the use in the right place, I think I'm very curious if you heard of companies or work to try to actually commercialize that technology and where they hit blockers.
I mean, it was way too early, right? Because we're talking like time sharing systems, right? So the screen that, Jack Myers was looking at and talking to was connected to a computer at Stanford, right? So this was time sharing days. And I still remember when the first Sun workstation came to the lab and we had our own computer, right? So the computing infrastructure just wasn't there. So you're absolutely right. It was sort of a research project. And at that time, they were, installing it in several large hospitals in Pennsylvania, right? That was the idea. Let's just install it in large hospitals. But yes, absolutely. It was a research project, right? You had to have people familiar with the vocabulary of the system, right? So this is going to be used by experts and a few people, at most, right?
And I think the other big difference is, and I would be curious to hear your thoughts on this, healthcare has changed a lot in the last 40 years. I wasn't around in the 70s, but I would imagine that healthcare was a little bit less rushed than it is today.
So let's talk about that, right? Compared to where we were, where are we now? And what do you see as the biggest sort of challenges and opportunities for using AI, right? Now, given that we've got all of this great technology, it's not mainframes, it can be on your phone, right? I mean, your phone is many times more powerful than the most powerful computers at that time, right? So given where we are now with technology, with machine learning, where it is, what are the biggest challenges and opportunities in using AI for healthcare? Just to sort of take a step back.
Yeah, let's start with that example we were just talking about a moment ago. So imagine a diagnostic aid for general medicine. Now everyone has a computer in their pocket, and it would be trivial to have that diagnostic aid running on someone's phone. And I think a key question is, well, how useful would that be? And what I see when I go to the doctor's office is very little time to talk to the patient, find out what's going on with them, figure out next steps, and get them out the door. So we're talking about a few minutes. Nowhere in those few minutes is there an opportunity to pull out a phone and start to do any sort of diagnostic workup. So I think diagnosis ends up being a very small part of what physicians are doing. It's something that they're very comfortable with and they're relatively expert at. And so there are definitely situations, for example, with rare diseases or very unusual presentations of diseases where having a diagnostic aid like that internist example you gave from the beginning would have been super helpful. But the vast majority of cases, I would think, that is not the pain point that physicians have today. So, but we're also in a very different spot now in healthcare because we have electronic medical records. And so we have data about patients being entered in almost real time into computer systems. And that presents opportunities to do all sorts of other things to really improve healthcare beyond just diagnosis.
Yeah, good point. But what's also changed a lot since those days is the type of data available about people. You can feed an image to a system, right? You can show the machine an X-ray or an MRI, right? Stuff like that. Couldn't do that those days, right? You had to basically, the physician had to describe the picture and say, well, I've got dark spots on the, on the left part of the lung, right? And so somehow the sort of amount and quality of data that machines had available to them those days just pales with what we have available now, isn't it?
I would say the amount, but not necessarily the quality.
Well, by quality, I mean, the quality of images even that were available then relative to now, let alone putting them into a system. I mean, to me, that just seems like night and day between what it used to be and what it is now.
I think if you're thinking about any data modality where you're getting some unbiased view of the patient, so an MRI is a good example of that. There, I agree with you. Or another good example would be, let's say you're taking a blood sample and you're doing a array of tests to see what proteins are present in that blood sample, or to understand the patient's metabolomic profile. There, we're getting just such higher quality data that it really opens the door to having a much better understanding of what's going on with an individual than you could have before. On the other hand, when I was questioning your comment about quality, it's because I was thinking about all of the unstructured data that you would find in electronic medical records. For example, the notes that the clinicians are writing, just because of the demands on documentation in the United States healthcare system being so large, concerns about liability being so ever present, that data is of arguable quality, and particularly if you're to compare it, I think, to the documentation of long ago.
So coming back to the question, so what are the challenges and opportunities, right? So you've sort of touched on the diagnostic side, where sort of my takeaway is, okay, we've got much better data, we've got better technology, we've got machine learning. We never used to have that. So given, where we are in terms of sort of the state of the art of AI and the availability of data and the state of technology in general, what do you see as the biggest challenges, right? Eric Topol also touched on the fact that physicians are rushed, right? People spend between 30 seconds and a minute or two with a patient, right? So clearly that's a big problem at the moment, is that there isn't enough time. People are just rushed.
Yeah. So I think we can look at the buckets in terms of different timelines of a patient's care, someone with chronic disease, for example. There's diagnosis and doing early diagnosis. And there, I think the more unbiased views that we were referring to earlier, whether it be imaging or proteomics, I think is an incredibly interesting opportunity. So I was really excited, for example, when Theranos was a thing, because I envisioned this world where everyone would be giving blood samples from a drop of blood on your finger on regular bases. And from those blood samples, we could do an array of different blood tests. And suddenly we'd get a dense view of a patient's health across time that allow you to do early diagnosis in a way that simply wouldn't have been possible before. And that one company has not survived, but I still believe in that vision. And I think we're going to see more and more of that type of thing in the future as we see cheaper and cheaper sensing modalities and ways to get those unbiased views of an individual's health. So I'd say that's one big bucket. And all of those are going to be enabled by AI. The second bucket is one of, well, once you find out that something is going on with an individual, so perhaps, for example, you've diagnosed a patient with cancer, what are the right treatments that would be appropriate for this patient? For many cancers, there are so many new treatments, but a very poor understanding of which treatments work best for whom. So we've been collecting all of this data from the practice of medicine, data about which treatments patients are getting, their past medical history, and perhaps the reasons why doctors even gave them those treatments. And then how do they actually do? So how long until their cancer progressed, or how long until they reached remission? What types of toxicity did they have to the treatment? What types of adverse events did they have due to the treatments? And that data gives us a lens in which we can start to build machine learning models to predict which treatments would be most effective for which patients. And I think that is a super exciting area. And machine learning is important for every single aspect of that process. Everything from extracting the data you need in order to do those analyses, like for example, the adverse event or toxicity, or even the patient's past medical history is usually written in clinical notes, and you have to use machine learning algorithms to understand those notes and extract information from them, all the way to actual machine learning models that can take what you know about the patient and do the prediction of what is going to be the optimal treatment for a patient and why. So in every step of that process, machine learning is essential. Now, if you go a little bit further out in time, think a bit less about diagnosis and treatment, but just what is it like to manage with chronic disease? A lot of that management is happening at patients' homes, and being able to have a better understanding of how a patient is doing when they're not in the doctor's office is going to be very valuable. So, for example, I have a colleague at MIT, Professor Dina Katabi, who developed what looks like a wireless router that would sit in someone's home and use wireless signals to sense everyone who's in the household, where they are. If they're on the floor, for example, they might have fallen, it would recognize that. It could also measure things like their heart rate and other information, and just do continuous monitoring in a non-invasive way that, again, starts to provide that view of an individual that really that goes across the different visits to doctor's office. Now, as a patient, for example, they're managing either your own chronic disease or those that have a family member is also really challenging. And I'd like to talk a bit about sort of where AI could help there. And maybe we could start with an example. Maybe you can tell me, Vasant, what are some examples of your own experiences with the healthcare system where they've been suboptimal? And we can talk about where AI could have really helped in each of those.
Well, thanks to COVID, I find that the logistical parts have improved, and whatever can be done remotely is done remotely. So operationally, I think things have gotten more efficient. On the diagnostic side, I don't sense an obvious sort of improvement in diagnostic capability or accuracy, but then I'm not measuring that kind of stuff, right? It's just that, so I have like PSA level issues at my age, the prostate becomes a problem, right? So that's something I'm keeping an eye on, as is my doctor. But I find that, when I got the results and I started looking into all the literature, it was all very confusing to me, what the implications were of my PSA levels. And I found that I wasn't able to get that much more information from, talking to the clinician, right? I said, explain this to me and explain that to me. And sort of the general response I got was, well, don't take all these things too seriously. That's It's a paper. It's complicated, right? Maybe the cohort there was white man, you're Asian, you're different. And similarly with, the other thing, of course, is statins. So I have a cholesterol problem, right? And so my GP said, well, take statins. And I'm like, but why? Am I at risk of heart disease if I don't take them? What are the side effects, right? And I find the medical establishment somewhat dismissive about the side effects, right? So I went and saw a specialist, who said, well, these are the AMA guidelines. And I said, can you point me to some peer-reviewed journal articles with large data sets that would suggest, to me that it's a good idea to take statins? And the answer is not really. So my own experience seems to be that physicians tend to follow AMA guidelines. Maybe it's because they don't want to get sued. Maybe because that's a good default thing to do. But I just find that there's personally not enough sort of focus on the individual nuances of a case.
Yeah, these are great examples. Can we dive into each one of those?
Sure.
So you started out by talking about PSA levels, so prostate specific antigen. So this is something which is tracked in men who are at risk of prostate cancer or who have had prostate cancer. And one can see those levels changing across time and say, okay, what does that tell me about my risk? And very similar tracking of biomarkers happens in many other diseases. So for example, in kidney disease, one might look at creatinine levels or EGFR levels across time. In blood cancer, like multiple myeloma, one would look at values of a biomarker called beta-2 microglobulin and how that's evolving with time. And a very relevant question is, you're seeing some trend. What does that really mean? What does that mean in terms of when's the right time to initiate a new treatment? What does that mean in terms of your risk of disease progression in the absence of treatment? What does that mean for you specifically with your lifestyle, your past medical history, and your genetics? And there are no good answers to those questions today. Now, that's something which machine learning researchers obviously have at the top of mind. And so I've had students at NYU, when I was a professor there, look at predicting disease progression for kidney disease. For example, how long until a patient with kidney failure is going to need dialysis? And you could ask, well, can we take the time series of their creatinine and other blood biomarker values across time and use that within machine learning models to predict time until dialysis is needed? And we conjectured starting out this project that looking at those time series from large numbers of patients and complementing that with lots of other information we know about those patients, for example, past procedures and diagnosis codes that tell you something about their comorbidities, that we would be able to do much better than some simple rules that your doctors might be using today. And what do you think we found?
I am curious.
We found that we couldn't do much better than the very simple rules, right? So the simple rules might look at, like, is the value greater than this threshold? Or if you're to try to create a derivative, like look at how much, what's the rate of change using the last two observations. It is extremely hard to outperform those types of predictors now, it doesn't matter how powerful of a machine learning algorithm you throw at it. It's very hard to outperform those predictors. And that's a finding that I've seen time and time again with data of the sort that we're talking about. And so, there are a couple of questions and lessons we can take from that. An obvious question is, well, why is it that the machine learning algorithms aren't able to get more signal out of the data? And one conjecture I have is because the data that they're making predictions on, for example, PSA as a biomarker, those biomarkers were chosen and they're being measured on a regular basis because they're very easy to interpret. So they're designed to be used in the way that they're being used. They're not designed to be used to get some subtle signal across time about them, for example. And so, medicine today, at least the data that we're collecting in medicine, is designed for human interpretation for the most part. And if we were to think about where medicine is going to go in the future, well, we're going to be if interpretation is not going to be done by a human, but by a computer, it opens the door to very different types of sensors and observations. So for example, well, why should we be looking at a single biomarker like PSA? Why not look at hundreds or thousands of different proteins or other molecules and use those combined measurements, and in particular their values across time, within our predictors? Once you start to get this more unbiased view of the patient, and I believe more and more biological research will be giving us new approaches at doing that, I believe we're going to start to be able to get much, much better in terms of predictive performance. So that's one comment, and I'll give you a chance to react to that before I get into the other examples you gave.
I want to keep that in the back of my mind, but I don't want to stop you because I like your train of thought. So go ahead. I don't want to sort of derail this, but go ahead.
So the next question is, well, okay, well, suppose we're not going to hope to get better predictive performance by looking at, for example, the time series of PSA values across time. But could we at least come up with more personalized predictions or more personalized conclusions based on what we know about you as an individual? And that gets back to the question I was raising earlier, one of how can we figure out which treatments work best for whom? But it's more than that. How can we figure out also what disease progression is going to look like for different people? And to answer those questions, you need really high quality data sets. And that's something we simply do not have in the United States. So for example, we would need to be able to have PSA values measured at unbiased points of time. So, PSA right now is currently being measured according to particular guidelines. So at regular intervals for men over some age, for example. And we would need to have a lot of contextual information. So for example, if we wanted to be able to interpret the PSA as a function of someone's genomics, we need to be able to have their genomics to accompany those PSA values. There are very few data sets that have, let's say, this triple of three things: genomics, PSA, and outcomes. For example, when was prostate cancer first detected? What stage was it? How did the patient do under treatment? Right. So if you just think about those three things, you need high quality data on those three things in order to answer the types of questions that you were asking your doctors. And that data simply does not exist.
So I will interrupt now, and I hope I don't break your train of thought, because, one of the things that I was thinking when you asked me about, what do you think about your personal experiences and the state of the healthcare system? And I guess one of the things I didn't say, but I will now, is that I feel that the medical system is highly specialized, right? That you're always seeing specialists,
Yep.
right? And I've experienced, I guess, two healthcare systems in my lifetime. Sort of the Indian healthcare system for the first 22 years of my life, and the US healthcare system for 40 plus years after that. And healthcare has changed. I've changed, but I can still sort of make some gross high level comparisons, which is that it seems like much more specialized in the US, and maybe that's the way India is going as well.
I think it's a huge problem.
Yeah, because, there's a specialization, and even the cardiologist I was talking to said, look, it does lower cholesterol. You take the statin, it will have that outcome. And I'm like, yeah, but what about everything else?
Yeah.
That you are not interested in? Like, what happens to my muscles? Does it do anything to my mind? There's other things that you're just not interested in looking at because that's not your job, right?
Yeah, everyone is getting
like
very narrowly focused on that one thing that they're responsible for. And that's not what patients need.
So now that I'm sort of thinking about it, I'm saying, okay, so the reason these machine learning models don't do as well is because they're looking at the same old data and hoping to somehow extract signal from it that humans aren't able to, but in fact, they're just looking under the lamppost because that's where the light is, right?
Yes.
It's like you said, right?
Yes.
The healthcare system was instrumented for human interpretation. And to a large extent, it's still that way. Whereas now what we're sort of moving into is an era of all kinds of new sensors where the instrumentation actually favors the computer. The computer can actually perhaps make more sense of these other data modalities than humans can.
We're getting closer to having those better sensors, but we're not solving the underlying data problems that I mentioned. Because, for example, in order to make use of the in order to make use of, let's say, the sensor information, you need to, first of all, collect it. You need to couple it with other information about the patient. And if there's not a way to pay for that in today's healthcare system, then it wouldn't typically be collected or collated in the way that you would need. So, a good example might be genetic sequencing, where right now it's quite cheap, but it's not something which is regularly collected on everyone in the US. If you think about, let's say, an MRI, for example, an MRI is very expensive. It gives you a very unbiased view of an individual, but you don't have those views unless there is an indication for getting an MRI, where then the health insurer would pay for it. And so just because the technology is improving doesn't mean we're going to be getting the data we need in order to build the machine learning models that we dream of. There really is a catch-22 here, which is that machine learning needs a lot of data. But in order to get that lot of data, you need to demonstrate the ROI for it. And you can't demonstrate that ROI without the machine learning algorithms. So we're stuck.
But what's the way out of this catch-22?
There's no easy answer. I'd say there's a policy approach and there's a algorithmic approach. The policy approach would be to generate data specifically for the purpose of research. A good example of that is the US precision medicine initiative that was started by President Obama that is now called the All of Us initiative. This is a nationwide effort in the United States to collect data on over 1 million Americans drawn from a very diverse pool from across the US. Data which is unbiased in its nature in terms of collecting blood samples, for example, even outside of regularly needed doctor's visits, collecting genomics data, for example, and then making that available to researchers. So creating a dense data set for not everyone in the US, but for a small sample and funded nationally rather than funded through an individual's health insurer.
So, David, you've mentioned sort of biased and unbiased a few times. So I just want to push on that a little bit more, and I just want to make sure that we're on the same page. So what would be examples of biased data? Would physicians' notes be biased?
When I say biased, I mean biased based on the patient's existing diagnoses and the healthcare system's existing medical guidelines.
So let's say self-reported, right? So that's also part of the notes. So
self-reported, right? Would be an example of less biased or unbiased.
Yeah.
In the spirit of the way I'm using the word here.
Okay. And unbiased would be things like images, MRIs. So yeah, so would that be unbiased?
Yeah, I mean, suppose that you had someone get a full body scan every week of their life. Now, this would be a really bad thing from because of the depending on the radiation or the technology being used, but that would give you a lens on the individual on a regular basis that is not a function of what's known about the individual today or the way that medicine is being treated today. So I gave an example of a policy approach to try to get around this catch-22. Let me give you now an example of an algorithmic approach to get around the catch-22. I think the algorithmic approach is going to be to try to cobble together models, machine learning models, that are trained on very diverse data sets. So, for example, and I'll use this example later as well when we come back to your comment about medical system being highly specialized. So my mom had multiple myeloma. I think we probably spoke about this back when I was at NYU. Multiple myeloma is a blood cancer. And she ended up dying of heart failure. The heart failure was caused by the accumulation of amyloids, which are overproduced in the body due to the cancer in her heart. And so her oncologist, getting back to the comment about being highly specialized, her oncologist was highly focused on her cancer, not so focused on her heart. The heart is in the realm of the cardiology community and the cardiologist. And so, okay, they, despite the despite the fact that my mom had early signs of heart failure, and despite the fact that multiple myeloma actually is known to cause this condition called cardiac amyloidosis, because cardiac amyloidosis usually appears so much further down the line in multiple myeloma than the stage that my mom was currently at, it was not even suspected. So imagine what would it be like to have a machine learning model do early detection of cardiac amyloidosis for patients with multiple myeloma. Well, right now, echoes, which are one way to try to detect it, are not standard of care, not being done on a regular basis early in the disease stage for patients with multiple myeloma. And so it would be very hard to build a machine learning model to predict who has cardiac amyloidosis based on data that's generated today.
Mm-hmm. Mm-hmm.
Moreover, it's also very rare. And so there just may not be enough samples in the US, even if they had been taken on a regular basis. But amyloidosis does occur due to other conditions other than multiple myeloma. So you can imagine creating a data set of patients' echoes from those who have amyloidosis. They don't necessarily have multiple myeloma, but they have other conditions that lead to that buildup of amyloids in the patient's heart. And using that to build a model to do early detection of amyloidosis, and then maybe fine tuning that a little bit to make it better suited to patients who have multiple myeloma. Like maybe there are some small differences in how it presents, or maybe it's just having the prior information that patients with multiple myeloma are likely to have amyloidosis. So putting those two pieces together, the sort of knowledge you have about the disease as a whole and the detector that is now a bit more general beyond that single disease. And in this way, what I'm envisioning for the future of AI in this field to really address this problem I mentioned earlier is we're going to be cobbling together models learned from very different types of data sets. And we need ways of bringing them together and so that we can sort of see a patient as a whole, despite the fact that the training data never allowed for that by itself.
Interesting. Very interesting. I mean, it's almost like, maybe AI will help us see the more general picture, the bigger picture.
Exactly. That's going to happen.
Connecting things, right?
That's going to happen everywhere. So it's going to happen in the way I just mentioned, but it's also going to happen in just helping with communication. So imagine that you're an oncologist and think about the example I just gave you about my mom, and you're seeing a patient for their next follow-up visit. Right now, they have a very limited amount of time to figure out what's happened to this patient since the last time they saw them, right? So maybe reading over the most recent pathology and radiology reports, looking at their own note that they wrote the last time they saw the patient to remind them about this patient. But they probably don't have time to do a detailed look through what the cardiologist wrote in their note or what the patient's primary care doctor has been reporting about how this patient is doing outside of the narrow lens of the patient's cancer. And so imagine now that you have AI algorithms that can take all of that data that you have from these different specialists, right? Getting back to this problem of medicine being highly specialized, and start to synthesize it into a report that oncologist could read right before their follow-up visit. And that report summarizes not just what's going on with the patient's cancer itself, but also what is the cardiologist finding? What is the primary care doctor reporting? And helping connect the dots across these, right? So maybe giving a little call out that, cardiologist is managing these early signs of heart failure, and don't forget that heart failure is associated, that multiple myeloma has a risk of leading to cardiac amyloidosis, right? And you should keep this in mind. So starting to really connect those dots for the specialists in ways that they're not currently doing today, not because they're not interested, just because I would say medicine is so highly specialized and they're so limited in time.
Very interesting. That is so interesting. And it sort of gets me thinking about sort of the role of modern AI in making this happen, right? So on the one hand, we're talking about the need to have the right kind of data, like diverse data that can help you make the connections, right? And we started this conversation by talking about discourse and the ability of a computer to actually have a conversation with a specialist. And sort of this leads me right into sort of language models and the role that these new kinds of machines might play in healthcare, right? That it seems to me that in addition to being able to do better, to see more generally as opposed to myopically, there's this really important aspect of an intelligent assistant that's helping you literally, quote unquote, talk through the case.
Well, we have to think about what
Or,
the right
or
user.
am I dreaming?
Yeah, I think the question is, what is the right user experience? I'm not sure, for example, a verbal conversation or even a written conversation of a chat style is something that physicians want. It would be really interesting to do user studies to assess different versions of that. But language models, in particular, large language models, things like OpenAI's GPT-3, 4, and Anthropic's Cloud are going to be a huge part of how we practice medicine in the future from three different perspectives. So the first is around really the knowledge that they bring in from having been trained on the world's information. The second comes from their ability to generate text in ways that can really address the primary pain point of medicine today in the United States, which is that of physician burnout due to the documentation burden. And the third, through their ability to really deeply understand language, and in particular clinical language, and in doing so start to connect the dots across clinical data in ways that humans either are not able to do or don't have time to do today. And I'm happy to dive into any of those three.
You expressed it a lot better than I did. But that's sort of what I was trying to get at with the language models, right? That they have the vocabulary already, right? They already have a lot of sort of background knowledge, right? So, I mean, the way I see this is that in the old days, or rather in the early days of machine learning, if you wanted to predict pneumonia, you sort of collected all the cases in a hospital and maybe you do better for that hospital. Yep. And not anywhere else, let alone another country, right?
Yeah. So let's start with that first bucket and go back to that internist one example, right? So in the example we gave at the very beginning of this conversation, those what are called expert systems were built by thousands of hours of time of clinicians entering medical facts into its database. And one of the many challenges of those systems is that they were very hard to maintain. So they never had good enough coverage of the diversity of clinical conditions or ways that they could be presented. Now, large language models, because of the way that they're trained, so for example, they're trained on Wikipedia, on PubMed, on patient forums and doctors' forums, they have built into them a rich understanding of clinical concepts. So for example, one could go to a large language model. For example, you go to ChatGPT today and ask it to list the symptoms for a patient who has congestive heart failure. Or you can even ask it, well, what treatments are commonly used for congestive heart failure? And it'll give you an output which is very, very good. About as good as you would get by doing a Google search and trying to collate the results yourself, or about as good as you would get from a medical textbook. And so those models already have a very deep understanding of the types of information that were present in these expert models from 40 years ago. And they didn't have to be manually entered, which means that their coverage is substantially better than those original expert systems.
And how often do these models hallucinate?
Well, so just to recap what hallucination means in this context, if you're doing text generation, so you're asking a model to output something. I'll give an example, maybe say, okay, here, an example coming from healthcare is something that Epic, which is one of the commercial electronic medical record systems, is working on together with Microsoft and OpenAI, which is to use OpenAI to answer to come up with a first draft of patient portal messages, of responses to patient portal messages. So imagine you're a patient, you go to your patient portal, you send a message to your doctor saying, recently I've been having this aggravation of my condition. What do you suggest I do? And the on the receiving end, whether it's a nurse or a physician, they can start with a first draft response coming from one of these models. And you can imagine that the draft response first starts by really, just like the internist example we started in the beginning, that expert system starts by regurgitating in essence what they understood about the patient's concerns. So they might say, okay, I understand that you've been having a lot of trouble sleeping for the last 2 weeks and increased anxiety. Both of those might have been mentioned in the original patient message. But suppose now that patients who usually write messages about having trouble sleeping and increased anxiety also have trouble with something else. Maybe you can give me an example.
They've got a ringing in the right ear.
Fine, a ringing in the right ear.
Which just occurs randomly. Another one of my conditions.
So maybe it doesn't occur randomly. Let's just suppose that example occurred with higher probability with patients who have trouble sleeping, right? So because of the way these models have been trained, they might output trouble sleeping, anxiety, and ringing in the right ear. Right? And so that would be an example of a hallucination because it wasn't something that was mentioned in the original patient note, but it's something that statistically is very likely to co-occur with the first two. And of course, if a patient were to receive such a message, they would say, wait a second, did they not read what I just wrote? And they would lose trust in everything else that would be in the remainder of the response. So that's certainly a very big problem.
I was actually thinking of a more subtle kind of hallucination, right? Something that actually sounds great, because it's written so well. It almost reminds me of this statement about these machines speak such good English, so we're having a hard time sort of taking them in.
Yeah, but we can really try to do an apples to apples comparison to those systems from 40 years ago. So those systems from 40 years ago, you can open up the corresponding databases and look to see, well, why is it that this symptom, is this symptom linked to this condition? If so, with what evoking strength, for example? And you can look at that, but if you were to look at today's large language models, well, which neurons or sets of neurons in these very, very large models are responsible for these specific facts? It's very, very hard to come to such a conclusion. And so the challenge is one of verification, even if you wanted to verify. And so that is something which I'd say that the whole AI and health community is very concerned about, but it's not something that I'm very concerned about. And it's something that I think the research community is going to be able to make very rapid progress at addressing that concern.
So, coming back to the large language models, I hadn't actually thought about this, but as you were speaking, I thought, wow, this is sort of ties into my notion of sort of operational efficiency, right? Efficiency with time and how you interact with your healthcare provider, right? So I was envisioning that maybe now we'll chat to them through portals, like through texts and images, and they'll come back to us with really good stuff. But maybe the front end that they're dealing with is an AI system, right? That's sort of doing that first level and sort of really doing some really heavy lifting there.
Yeah, and I think that's part of what makes the recent advances in telemedicine so exciting, right? So we were talking about what's changed in medicine due to COVID. Well, a huge adoption of telemedicine. Now almost everyone in the United States has used telemedicine in some way or another. Well, the moment your interactions with your physician start to have that computer screen in front of it, it opens the door to augmentations of the physician and of the patient at a way which is super exciting. Lots and lots of potential there. Just from a workflow perspective.
Yeah, I mean, I can imagine it would make everyone's time so much more efficient.
That's the hope.
Yeah.
I mean, it's not just about efficiency, it's also about just improving the experience, right? So what I'm about to say is not only relevant in a telemedicine context, but it's relevant to any time you have a visit with a physician, right? So how often have you gone to a doctor's office or had a telemedicine consult and come home and wondered what the heck just happened in that visit? what was I supposed to follow up with? What did they say my problem was? Wait, I'm supposed to take this medication how many times a day? Of course, you might hope that that would be in some pharmacy pamphlet, but it's particularly for patients with chronic disease, it can be very, very complex to really understand or remember the subtleties around a recent visit. Now, AI can really help with that. So it can help with it in a couple of ways. Well, one way is the recent explosion in products for what's called ambient documentation. These are AI algorithms that are listening on to patient-provider conversation. So imagine, you're talking to your doctor and there's a record button on their phone. So it's recording the whole conversation. And once that conversation is finished, it can output a summary of it for the patient, for example, or for the physician. Or it could, even for the physicians, generate a first version of a note that they would have to write to summarize the visit. Now, in a telemedicine setting, it's obvious that there could be recording of the visit, and it becomes much less creepy than you would imagine having the phone with the record button on in a doctor's office. So that's one example of where AI can be really helpful. Another example would be because of a major change in U.S. policy in the last couple of years, patients now have access to all of the notes that their doctors have written for them. This is something which was started by what was called the Open Notes movement in the US, with the idea that patients have the right to see the data that's being written about them and that it's going to be helpful for them. That was made into law and now enforced at a national level. And so you could go to your patient portal today and look at all of the notes written by your cardiologist, by the emergency medicine doctor who saw you, and you could try to use that to try to answer that question of what just happened in that visit and what were my follow-ups supposed to be. But now you're confronted with a different challenge, which is those are really hard to understand. They're not written for patients, they're written for physicians. And even if physicians were trying to write them for patients, they have another need for them as well, which is to help themselves remember the case for the next time or to help communicating across physician teams, right? So it's very hard to serve all these different use cases with just a single note. But imagine now that you have an AI algorithm that is sitting on top of the patient portal and looks at the patient note and starts to generate a patient-facing version of that note. So something that's much easier for us as consumers of medicine to really understand. Or imagine that it could generate automatically questions and answers. I'm actually doing a study on this right now. We're about to submit this paper for publication where we used GPT-4 to automatically create questions and answers around a physician note in the setting of breast cancer. And what we found was that we did these user studies with breast cancer patients, survivors, and they looked through their notes and they said, yeah, I never really understood this thing, or it took me, days of research to come to this conclusion based on my visit. And so we showed them the note, they gave us those questions, and then we showed them the automatically generated questions and answers coming from our system. And it was amazing to see the reactions in some of these user participants' faces, because some of the same concerns they just raised, things they never understood, the model just immediately output. These were the questions that they were wondering about, and here are the answers at a way that just gave them so much clarity around the medical note and around that visit that they had wanted and weren't able to get the first time around.
Can you give an example of that? Because, as you were talking, I was thinking of my own case where I got PSA results.
Yeah.
And then I did a Google search and I looked at a whole bunch of papers from the New England Journal of Medicine. I looked at results and blah, blah, blah. But I wasn't able to summarize and express them in a way that would have been really useful, right? So I sort of got stuck, and when I spoke to my physician, I said, well, but there was this study and I read blah, 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 but he didn't really have enough context to go on, right? So, to be fair to him, it was very hard to respond.
I would distinguish between two examples. One is giving a layperson explanation of something that doctors already know or is well established in the medical literature, and perhaps could be found with a large amount of research had you understood the node and knew what to research. And a different scenario is actually going into the medical, into the published literature, reading state-of-the-art results, right? Recent results that may not have made their way into clinical guidelines just yet. And so, in the first case, what we're trying to mimic here is just a conversation that you could have had with your physician, but didn't have at that moment. And there are things like, well, what is my disease? And what is my treatment plan? Things that are mentioned in the note, in code, in essence. So it's written for physicians, but not for patients. And just translating that into ways that patients can much more easily comprehend. The second example, right, of really going to the medical literature is also really interesting, but that's not the one that I was giving earlier. That is a very fast-moving research topic, and there are also several companies that are working on using large language models for that purpose of summarizing the medical literature. It's not something that's easy for so many obvious reasons, right? Because it's very hard even for humans to do, and there are often no clear answers.
Yeah, I can see that. But even though there aren't clear answers, there's value in sort of being able to walk through what the issues are.
So, yeah, a couple of the use cases that I'm seeing. So one of them has to do with just keeping clinical guidelines up to date. So there's actually a company called Up to Date. It's a resource, you can go uptodate.com, that is used by most physicians in the United States, and you can think of it as an encyclopedia of how you would treat and manage any medical condition. And it's maintained by a team of editors for every condition has its own team of editors who scour the medical literature, see what's known, and summarize it in a way that any physician could quickly look up and figure out what is known today, what is best practice today. And that process of keeping that up to date, keeping that resource up to date, is very challenging, very manual, very time consuming. And so one could imagine using AI algorithms to read the medical literature and automatically create those summaries in ways that might be much fresher in content than would be if they were done manually by humans.
And maybe also to like fine tune things like ChatGPT.
Well, yeah, that same information would be very valuable for learning large language models, but I would argue that large language models already are trained on that same information. So PubMed, which is the place where many articles in the United States are deposited, is one of the key parts of the training set of most commercial and open source large language models.
There's a lot of interest today in sort of tuning these language models, large language models, for specific kinds of tasks or domains. Is that sort of where you see some of this research progressing, that there'd be a med GPT that's like a large language model that's better than ChatGPT, and it's actually its thing is medicine? Or do you see sort of ChatGPT being sort of the all-encompassing thing that just knows about everything?
That's a really complex question. There are no obvious answers today. It's a big part of my research at MIT, and also my work at a startup company that I run. So what I can say is the following, which is that to really understand language is something which goes across particular applications and domains. So the best of commercial large language models are just extremely effective at understanding language itself, independent of the domain. And that's something that is very valuable and very hard to make into, let's say, a small model that could run on your phone, for example. Now, the consequence of that is that it also has a huge amount. So beyond just understanding language, if you think about the knowledge-based components of large language models, so knowledge about facts of the world that are encoded in their weights, for example. It'll include a lot of unnecessary information. Like there's no need to know about baseball players and their statistics in order to answer questions for medicine, just as one example. And so you might hope that by having more specialized language models, one could get much more compressed models that are cheaper to run, for example. I wouldn't necessarily argue that you would get more accurate models, because I never cease to get amazed by just the wealth of clinical knowledge and really knowledge in other domains, specialized domains as well, that you could get just from reading all of the publicly available information on the web, as has been done by many of these commercial LLMs.
Coming back to or trying to wrap up in terms of like, where do you see the sort of biggest opportunities and innovation happening in AI across those areas that, you started with, which was, I guess, fell into, earlier diagnosis, better treatment, or just sort of overall, management of care. And we touched on all of these, and it seems like they're all really, really rich areas for improving healthcare. Where do you see the innovation happening, or the lowest hanging fruit across these areas?
Well, for me, I'm particularly excited about understanding clinical language and getting value out of clinical text. So we've been talking about throughout today's conversation, there being an information problem in healthcare, right? Imagine that you want to answer this question of what your PSA levels mean in the context of your medical history, and trying to answer. Imagine you're trying to answer that now from data. Well, we would need all sorts of information to answer that. We have to have a good understanding of your medical history. We also have to have a data set that has those PSA levels together with those outcomes, the interventions that patients had, in order to do the type of causal reasoning that you would want for getting the answers that would guide your care. And to get that data requires reading through hundreds of thousands, if not millions, of patient records from other men who have had PSA tests, and some of them who have had prostate cancer, and extracting that information from all of those records. And that's something that's just not possible to do today because it's too expensive. It just requires a huge amount of effort to really go in and read all of those patient charts. And that's something that large language models, I think, are really good at, is taking information and extracting structured, valuable insights from it, such as the ability to extract the data set you would need to do that type of analysis. And that shows up all throughout medicine. It shows up in really being able to understand, build the data sets needed for precision medicine, as I was mentioning. It comes in and understanding quality, like, which hospitals should you be going to get your open heart surgery? Well, to answer that question, you want to understand, well, what types of patients are going to those hospitals today and what are their outcomes? And all of that information is found in the medical records. You have to extract that from there. It shows up in how everyone gets paid in healthcare. If you think about the way that healthcare is billed for, you have to read the records of the visit, see what procedures were performed, and extract and produce a number of procedure and diagnosis codes that can be sent to a health insurance company to get paid for that service. All of these really require deeply understanding the medical record. And today, it's just too slow to do that and too expensive to do that. And that's where I think large language models are going to have some of the most immediate short-term impact. And that's the focus of the company that I just launched a few months ago with several of my MIT students and clinical collaborators.
Interesting. Say more about the company, if you can, or if you'd like to.
The company has a name. It's called Layer Health. And our long-term goal is to really become that AI layer for the healthcare system, to do a lot of the things that we've been talking about through today's conversation. It's going to be a long journey to get there. And we're starting where I just mentioned, but I've got an amazing team.
Cool. That sounds really exciting, David. Good luck with that. So I really want to thank you for the time. I've really enjoyed this conversation and learned a lot, both in preparing for it and talking through this with you.
It's always good to see you, Vasant.
Yeah.
Hopefully in person next time.
Yeah, for sure. Good stuff. Yeah, maybe when I'm in Cambridge or when you're in New York City next time.
I'd like that.
So before we wrap up, I'm guessing you don't really have time to binge watch between your startup and everything else you're doing. But
no, not so much binge watching now.
I was going to ask you if you do binge watch, what's your favorite medical show or health show?
Oh no, I don't have one of those.
No time for that.
Well, I mean, I have I'm not necessarily thinking about healthcare when I'm not at work.
Fair enough. All right, David, thanks again. I really enjoyed it and look forward to catching up in person.
Thanks so much for having me.